Yes, good afternoon. Is my voice clear and audible to all of you? Is my voice clear and audible to all of you? Previously, we have discussed about diphtheria. We have discussed epidemiology of the diphtheria. Now, we are going to see today about clinical feature. Of course, we have discussed last time about clinical features, but again, we are going to quickly go through the clinical features and then we will see about prevention and control of diphtheria. So, can you write down what are the clinical features of diphtheria? We have previously discussed. What do you remember? What are the clinical features of diphtheria? Please write down in chat box. What are the clinical features of diphtheria that you remember? Write down in chat box. What are the clinical features of diphtheria? Write down in chat box. I am waiting for your reply. Which clinical features do you see in diphtheria? Any pathognomic sign you remember about diphtheria? Write down in chat box. Yes, I am waiting for your reply. What clinical features of diphtheria do you remember? Any pathognomic sign do you remember about diphtheria? I'm waiting for your reply. We have already discussed previously. Or if you remember types of diphtheria, clinical features of diphtheria. No, I'm not getting any reply from your side for clinical features. Do you remember types of diphtheria? Or most common age group in which diphtheria occurs? I have given 3 different questions. Okay, I'm getting now some reply. Soreness, malaise, fatigue, shortness of breath. Not typically. Okay. Laryngeal, yes, types are laryngeal, tonsillar, pharyngeal, very good. Okay, Kinjal has replied. Neil has also replied. And fever, sore throat, malaise, greenish white membrane. Yes, that is the pathognomic sign. Very good. Manish has replied that this membrane formation in mouth, that is typical clinical feature of diphtheria. Okay, so we are going to see it further now. Just a second. Okay, so onset of disease, we have already previously discussed about this, so I will quickly go through these clinical features, and we have to discuss about complication as well as we have to discuss about prevention and control. Right, so rarely the sudden symptoms are infrequently severe. Infrequently means symptoms are generally moderate or mild. Moderate temperature, that is 102°F, malaise, sore throat, yes, tired feeling. Students have, all of you have, those who have replied, they have mentioned this clinical feature. It is very right. Malaise, sore throat, tired feeling. Sore throat, it is not marked initially, and this delays the recovery of the illness. Membrane formation, it is due to necrosis of epithelial cells. Remember this. This membrane is typical clinical feature of diphtheria, so you have to remember in detail about the membrane formation. Why this membrane is formed? That is because of the necrosis of epithelial cells, plus there is accumulation of the serofibrinous material which form this greenish white membrane. Edges of this membrane are curled or separated from underlying mucus, and this membrane bleeds on peeling. Means if you touch and peel this membrane, it will bleed, and there is increased toxin absorption in this membrane, in this blood. So that is same blood on peeling. Usually one tonsil is involved, but soon it spread to the another tonsil opposite side. Right? Patient is discovered late. If it is discovered late, so extension of this membrane from tonsil to fuses to pharynx. So this initially this membrane involves one tonsil. It can soon spread to another tonsil, and it can spread to the pharynx area also. So if the patient presents late to the doctor, then extension of the membrane from tonsil to pharynx can be also seen. So membrane is widespread, it is seen in mouth. So in mixed-infection by secondary bacterial invasion, it is called septic diphtheria. So along with the diphtheria, if there are another bacteria, so it will be considered as the mixed infection. And this type of the mixed invasion by involvement of the secondary bacterial infection, it will be considered as the septic diphtheria. And in septic diphtheria, there will be high-grade fever, atypical appearing membrane, and greater inflammation in surrounding structure. So again, clinical feature can be described as local inflammation, membrane formation, and toxemia. And forms you already have replied: tonsillar form, pharyngeal form. Tonsillar form means the diphtheria involves tonsil, right? Then it extend to the pharynx and it involves the pharyngeal form. It extend to the larynx and it involves laryngeal form. Then enteral nasal and other forms of diphtheria can be also seen. We have already discussed about this. So tonsillar form is the most common type of the diphtheria. Right? Do you remember this? We have already discussed tonsillar form. It is the most common type of diphtheria. Right? So previously my question was about which is the most common age group. So some students have also replied about that question, most common in school age group. So it is right, 5 to 15 years of age. And just a second, there is some error. Okay. So initially this membrane spot few millimeter on one tonsil and more often identified on two tonsils. We have already seen as grayish yellow or grayish white membrane. Narrow area of redness, it surrounds the membrane. It is tender and enlarged submandibular lymph node can be seen on this membrane. So along with the membrane formation around the submandibular region, you know that submandibular is just below mandible. Lymph nodes are there. So these lymph nodes are also infected and they involved. They may be seen enlarged or it can be palpated if they are not visualized, but they can be palpated in some of the cases. And if you palpate this lymph node, it can be tender, means it gets pain on this palpation. So you can see membrane formation here. Membrane is there, grayish yellow membrane, yellowish membrane is there. Again, you can see membrane over the tonsil. Yes, over the tonsil, membrane is seen over here, right? Pharyngeal diphtheria, it involves the both side of uvula. Uvula, you know that in uvula, middle structure, in longitudinal structure, it is not seen in the photograph. Uvula is the middle structure. I have already told you previously that if you ask the patient to say ah, it can be prominently seen, right? So here, membrane spread to the sides of the uvula, spread of membrane anteriorly up to the teeth, and from postpilar to nasopharynx to nostril. So now there is extension of this membrane from tonsil to pharyngeal area, and that is called pharyngeal diphtheria. Early form membrane gets necrotic as newer parts advance. So previous whatever the membrane was formed, it gets necrosed, and newer part gets involved. So this necrotic material, it produces the foul smell. So whenever the membrane get necrosed, so this necrotic material will give us the foul smell, and this is called as foetor oris. Oris means oral cavity. Foetor means smell, foul smell. So foetor oris is foul smell from oral cavity. Why? Because of the necrosed material arising out of the previously formed membrane, or just because of the necrosis of the membrane. You can remember. When bleeding occurs, the membrane becomes foul black mass of the tissue. Throat tissue is congested. One of the typical signs is bull neck. That is because of the swelling of the tissue in front of the neck, and lymph node are not palpable. So bull neck we have already discussed previously. Bull neck is because of the swelling in front of the neck, right? We have seen previously. Laryngeal diphtheria. It's most commonly due to mitis type of the diphtheria, right? Mitis, that is the strain of the diphtheria. It is secondary, spread from the feces, may spread to the trachea, bronchi, and bronchiole. So because of the laryngeal diphtheria, there can be obstruction of the larynx, and it will lead to the huskiness of the voice, crappy cough, inspiratory distress. Inspiratory distress is what? Whenever you inspire the air, you will not be able to inspire properly. Distress will be felt. Patient will feel distress because there is obstruction in the larynx, laryngeal cavity. It will lead to the distress. Right? Stridor is what? Write down in chat box. Do you know the meaning of the stridor? What is meaning of stridor? Write down in chat box. Till we discuss further. And it is more common in children. Danger of laryngeal diphtheria is asphyxia. Okay, why asphyxia? Because there can be total obstruction of the larynx because of the membrane, and it will lead to the total absence of inspiration. Oxygen will not get inspired, and so that there can be asphyxia because of the blockage of the laryngeal cavity. I have asked you the question about stridor. So in this condition, whenever the laryngeal diphtheria is there and it may lead to the asphyxia, tracheostomy, it can be give the relief. Tracheostomy is the surgical operation where here in neck region, a hole is made and patient has to inspire through this hole, right? So in neck region, right? So here in neck region, a hole will be made because this part, nose part and the pharynx part, they are blocked. So patient will inspire through this hole made over the neck region. So that will give to the relief in case of the asphyxia. Okay, I have asked you the question about stridor. No one has replied. What is stridor? What do you mean by stridor? Write down answer of the stridor in your chat box. What is stridor? Till we are discussing further. Anterior nasal type of the diphtheria. Here in anterior nasal type of diphtheria means there will be involvement of the nasal cavity. So there can be discharge, which is initially thin, and blood stained discharge, which later become thick and mucopurulent. So thin discharge and blood stained discharge from the nasal cavity become later on nasal thick and mucopurulent. This discharge contains this bacteria, Corynebacterium diphtheria, which is the causative organism of diphtheria, Corynebacterium diphtheria. Thin yellowish membrane is also present in anterior nasal type of diphtheria. Other form include non-respiratory form. So till now we have discussed tonsillar form, tonsillar, pharyngeal, laryngeal, and anterior nasal. These are the respiratory form of the diphtheria. You know the tonsil, they are in respiratory part, respiratory system. Larynx, pharynx, this anterior nasal, they are the part of the respiratory system. So let me check whether you have replied or not. Nobody has replied about stridor. No. Okay, so I have also told you previously that stridor is typical voice whenever air passes, typical voice like a city, right? Whenever the air passes through a narrow membrane, narrow pathway, narrow cavity. So the voice is that type of the voice is called stridor. Just I can give you the example that whenever you blow into the cover of the pen, right? Whenever you blow over, you keep the cover of the pen over here and blow. Whatever the voice is coming, that voice type of the voice is stridor, right? Now, okay, we have just discussed about the clinical feature. Now again, yes, yeah, one student has replied abnormal high pitch breathing sound due to blockage. Yeah, so because of the blockage, there the respiratory cavity, pathway, it becomes narrow, and that type of the voice, typical voice, is arising out from the patient. That is called stridor. See, normally whenever you breathe in and breathe out, normally you do not get any type of the voice, right? Just observe yourself. You are not hearing any type of the voice. But in case of the patient who is having the blockage in the respiratory pathway, that type of the voice can be high pitched voice can be heard. Okay, now mention the characteristic of the membrane. Just we have discussed. What characteristic of the membrane do you remember? Characteristics of the membrane. That is the main clinical feature of the diphtheria. So you should remember the membrane. So whatever the characteristic of the membrane you remember, write down in chat box. Till then we are discussing further. So other forms are skin, involvement of the skin by diphtheria, eye, intestine, genitourinary form, and diphtheric endocarditis. I think we didn't go into the detail of these other forms. They are the parts of medicine also, but mainly you have to remember about the respiratory form. Just remember the organs, name of the organ that can be involved by the diphtheria: skin, eye, intestine, genitourinary system, and diphtheric endocarditis. So what is correct? What are the characteristics of the membrane? I have asked the question. What are the characteristics of the membrane in diphtheria? Skin, it is most commonly seen in tropic, seen mostly finger and back of the hand involvement, right? Punched out ulcer can be seen. We have the one photograph of that ulcer. Eyes, here also involvement of the nasolacrimal duct, conjunctiva, it manifests as the conjunctival diphtheria. No need to remember in detail about these other forms, just we are going quickly about this. Slugging of the conjunctiva and corneal damage can occur, and rarely there can be panophthalmitis. So skin, you can see the skin sore, the skin ulcer. Sore is ulcer, punched out lesion. You can see the, because of diphtheric involvement, the skin ulcer. Intestine, because of the involvement of the intestine, there can be dysphagia, bloody diarrhea. Right? Urogenital system, it can lead to the involvement of the coronus sulcus and glands. These are the parts of penis. In female, vulva and vagina can be involved. Diphtheric endocarditis means involvement of the heart. Right? So have you replied about characteristics? Yes, membrane is necrosed, grayish white membrane, bleed on touch. Very good. Hardik, Neil, and Munish have replied. Yes, Ishita has replied grayish, yellowish membrane, bleed on touch. Right. And do you know about smell? We have mentioned about the smell. Why there is smell? And what the word is that for smell? We have mentioned about one word. Why this typical type of the smell is arising out? And what is that word? Write down in chat box. So complications of diphtheria, that complications are because of the toxins liberated from the Corynebacterium diphtheria. Severe complications can be seen in nasopharyngeal form and laryngeal form of the diphtheria. So earliest severe complication of the nasopharyngeal diphtheria is myocarditis, right? And complication rare are nasal. So we are not going to the detail about the rare complication. Just remember that myocarditis, it can be the earliest severe complication, and they can rarely cause this otitis media, albuminuria. Don't need to go into the detail about these complications. So myocarditis, it can be, just remember the name of this complication, myocarditis. In community medicine, you will not to remember this part. You can go into the detail whenever it is discussed in medicine part. We are more interested today about prevention and control, right? So Foeter oris, not just Foetry, that is Foeter oris. Sandeep has replied that typical type of the smell is arising out whenever there is necrosis of the membrane. Just pay attention in the lecture. Whenever you are, if you just pay attention, then you can learn lot of things, right? It was just one type of the revision. So this typical smell which is arising because of necrosis of the membrane, right? Necrosis of the membrane, and that smell, that foul smell, it is called as Foeter oris. It is coming out from the oral cavity, so it is Foeter oris. Right? So we are not going to detail about the complications, ECG changes. There can be paralytic complication as well. Just remember, right? If eyes are involved in paralytic complication, there can be blurring of the vision, paralysis of accommodation. Now, diagnosis of diphtheria. Diagnosis is based on clinical diagnosis, laboratory diagnosis, and diagnosis susceptibility. So most commonly, we can diagnose diphtheria by clinical diagnosis. That is typical presentation of the diphtheria. And you know that Typically, the membrane formation, grayish white or grayish yellow membrane in mouth. It is the typical sign of the diphtheria by which you can just recognize this disease. So, clinical diagnosis is important in case of the diphtheria. Then laboratory and diagnosis separately. So clinical diagnosis in case of the facial diphtheria, thick yellowish membrane. We have already seen black in center, patient looks ill. Pharyngeal diphtheria, bull neck. Whenever the pharyngeal diphtheria is there, so this neck will be involved, and this bull necks because of the swelling of the diphtheria, swelling in case of the pharyngeal region. Lymph node are not palpable. Laryngeal diphtheria, here typical membrane is observed with the instrument called laryngoscope. See, whenever the membrane is present in oral cavity, you can easily recognize the membrane by opening this oral cavity. But whenever this membrane is present in laryngeal part, so you have to use an instrument called laryngoscope, right? So with the help of the laryngoscope, this laryngeal diphtheria can be recognized, and dry crappy cough is present. Nasal diphtheria, here in nose also anterior nasal type of diphtheria, membrane is seen along with the septum, nasal septum. This middle part is nasal septum, and turbinates. These both are turbinates. There can be diphtheric paralysis, right? Laboratory diagnosis. For laboratory diagnosis, you know that before going into the this laboratory diagnosis of diphtheria, tell me that how laboratory diagnosis of corona is being done. Do you know how laboratory diagnosis, which samples are taken for laboratory diagnosis of corona? Which samples are important? Write down in chat box. Which samples are taken for laboratory diagnosis of COVID disease or corona? Reply quickly. Samples which are useful for diagnosis of COVID disease. Which samples are taken? No answer? Or it is taking time to read me the answer to reach up to me. Which samples are taken? Yes, swab. Yes, very good. Many students have replied. Nasal swab, right? Yes, very good. Nasal and throat swab. Yes, very good. Yes. SpO2, it is not sample. SpO2 is one of the indicator that whether the condition of the patient is mild, moderate, or severe, right? But sample for this is nasal and throat swab. So similarly over here, nasal and throat swab. Throat swab or swab came from the nose, larynx, or skin, depending upon the condition, depending upon the lesion, it can be taken. It is not necessary that we have to take all this swab, right? If there is involvement of the larynx or pharynx, throat swab. If there is involvement of nasal, then nasal swab. Laryngeal involvement will lead to the larynx, or if there is skin ulcer, then skin swab, right? It can be taken and cultured. So culture medium is here Loeffler serum. In microbiology, you may have heard about this media, culture media. This is Loeffler serum slop. In doubtful cases, animal inoculation may be done by subcutaneous route, but it is not routinely being done because typically this membrane formation, it is clinical diagnosis is confirmed with the help of the membrane formation and Loeffler serum slop. Smear staining by Albert stain and serological test can be also done. So this is Albert stain in which Corynebacterium diphtheria, typical look of the Corynebacterium diphtheria is there. They are arranged in V-shaped form, as you know that here you can see V form. Right? Virulence test, there are two virulence tests, just you remember the name. In vitro test and in vivo test are there. One of the test is elect gel precipitation test and tissue culture test. We are not going into the detail of this virulence test because it is a part of microbiology. And another name you remember, sick test. Just remember name, elect gel precipitation test and sick test. In microbiology, short notes on this sick test and elect gel precipitation test are asked, right? So prevention and control of diphtheria. Do you, before going into the detail, do you know how diphtheria can be prevented? What do you know about prevention of diphtheria? What do you know about prevention of diphtheria? What is mode for prevention of diphtheria? Is there? Yes, vaccine. Yes. So vaccine, diphtheria vaccine is available since long and it is given routinely. Vaccination, very good. Emma, Hardik have replied. So for prevention, vaccine is very much useful. And before that, management of the diphtheria, we have to also see control, right? And so here we, along with the prevention and control, we are going to see first of all management of diphtheria. Of course, it is the part of medicine, but briefly we will see about this. Just a second. So by clinical examination, you see in clinical examination, typical membrane, direct staining using Albert stain, Loeffler serum swab culture, fluorescent antibody technique, toxigenicity test like Alex gel precipitation test, and sick test of susceptibility. So this slide is very much important. Clinical diagnosis, Albert stain, Loeffler serum in culture. This is direct microscopy. This is culture. This is serological test, fluorescent antibody test. Toxigenicity test is Alex gel precipitation test. Diagnosis susceptibility by sick test. So in nasal diphtheria, differential diagnosis, which can be other part. If the diphtheria is there, right? So differential diagnosis, we have to keep in mind whenever we suspect nasal diphtheria, it can be foreign body in nose, rhinorrhea, snuffles, official diphtheria. There can be streptococcus membranous also in tonsillitis, acute streptococcus membranous tonsillitis, viral membranous tonsillitis, herpetic tonsillitis. These are other differential diagnosis we can put whenever we are suspecting of the diphtheria. In case of the laryngeal diphtheria, croup, acute epiglottitis, laryngotracheobronchitis. These are the peritonsillar abscess, bronchopneumonia. See, these are the conditions which you may learn in detail about in ENT. Right? These are the parts of ENT. This you can learn in also ENT subject. Treatment of case of diphtheria. So first of all, whenever we have the confirmed case of the diphtheria, first thing we do is isolation. Like in case of the corona, we also go for isolation of this case. Why we go for isolation? Write down in chat box. Why in case of the corona or why in case of the diphtheria? First thing that we do, that is we isolate the patient. Why we isolate patient? Write down in chat box. So second thing is, I am waiting for your reply, and meanwhile I am also discussing other part. Then second thing is neutralization of the antibody by administration of the antitoxin. We have the antitoxin. You know that Corynebacterium diphtheria liberate toxin. So we have to neutralize this toxin by giving proper antitoxin. Then antibiotics to eliminate diphtheria, supportive and symptomatic therapy, and management of complication. I have asked why we go for isolation. Write down in chat box. So here isolation, it should be for at least 14 days or until proved free of infection. Like in case of the corona, we are also isolating patient for 14 days. Actually, it is not hallmark that every time we have to isolate patient in every disease for 14 days. It is not for, it's not same for all the patients. I mean to say not same for all the disease. We have to isolate patient for double incubation period, right? Double incubation period. Here in case of the diphtheria, the incubation period is 2 to 6 days. So maximum incubation period is 6 days. So we can isolate for 12 days, but roughly we can say 14 days, easy to remember in many of the diseases there are. At least 2 consecutive samples taken from the site 24 hours apart should be negative before terminating isolation, right? Before discharging the patient, before we say that the patient is now out of the isolation, right? We have to take 2 samples 24 hours apart and it should be negative for diphtheria. Like in the case of the corona, previously we were doing like that before discharging patient from isolation ward, we were taking 2 samples, right? And 24 hours apart. One sample if taken today, and if it is found negative, second sample should be taken next day, same time, and it should be also negative. Then patient can be discharged. But guideline is now changed since many months, that before discharging patient, we need not to go for this test, right? In case of the corona. So I have asked that isolation will decrease the spread. Yes. Hardik has replied, isolation will decrease spread of infection, spread of disease among other patients, other persons, healthy persons. Antitoxin, it is interfere with the action of the toxin and modify the attack, right? It is administered as soon as the infection of the diphtheria is suspected. So whenever there is a case of diphtheria, antitoxin should be administered. It can be given by IM or IV route, right? After testing the sensitivity to antitoxin serum. After administration of antitoxin, patient is observed closely for anticipated reduction in constitutional symptom. Whenever we give the antitoxin, we can expect that constitutional symptom like malaise, tiredness, it can be removed. Toxemia, it can be also decreasing. Dosage of the antitoxin depends upon the duration of the illness and extent and severity. You can if you do not remember this dose, it can be okay. Just remember the antitoxin should be given, right? So it ranges from 20,000 units to up to 1,20,000 units. Right? Antibiotic, it can help to terminate the toxin production. When we give the antibiotic, diphtheria, Corynebacterium diphtheria, this bacteria will be killed so that no further toxin production can be there. To limit the proliferation of the diphtheria, antibiotic can also prevent the spread of the organism to contacts and prevent the development of the carrier state. So for this antibiotic, procaine penicillin, this penicillin is given, oral penicillin can be also given, and erythromycin can be given. Just remember the names of antibiotic. Dose is for procaine penicillin 3 to 6 lakh unit, IM 12 hourly, oral penicillin 125 to 250 milligram, QID means 4 times a day, this oral penicillin tablet, right? There are penicillin G preparations, some of the oral penicillin, as well as some penicillin derivative, amoxicillin, ampicillin, these are the oral penicillin, right? Erythromycin also 25 to 30 milligram per kilogram per day is given. Now, one most important thing, clinical infection does not result in immunity. It is not sure that if we get diphtheria, then we are immune to the diphtheria further. There can be also a chance that we can get second time diphtheria. So attack should be followed by active immunization. Whenever the patient is having diphtheria, patient should be after the management, after the patient has been out of the diphtheria, free from diphtheria. Again, we have to give immunization to prevent further second attack of the diphtheria. So it is not so like in case of the measles or chicken pox. It is that the one attack protects the child from lifelong it gives the lifelong immunity, and it can protect from further attack. But in case of diphtheria, it is not so. Supportive therapy, bed rest for 2 to 3 weeks, avoid sudden exertion, observe the patient closely for changes in rate and rhythm of the heart to see the myocarditis. Antipyretic and sedative may be given also if required. Easily digestible high calorie diet should be advised. Treatment of complication. In case of the myocarditis and toxemia, absolute bed rest, only essential nursing care, hypertonic solution of the glucose, steroid, digoxin, all these are the parts of medicine, right? In case of the paralysis, palatal paralysis can be there, pharyngeal paralysis, or depending upon the type of the paralysis, like in the pharyngeal paralysis, we can give, if the palatal paralysis and pharyngeal paralysis, nasal gastric tube should be inserted for giving food, as well as for suction of the mucus. It is also second thing. Respiratory obstruction, whenever there is respiratory obstruction because of the laryngeal paralysis, we have to give humidified oxygen and go for tracheostomy tube. So treatment of contact, again same, but we are more interested in case of the in vaccination. So you know that the vaccine, name of the vaccine, right? We are prevention in vaccine. You know the DPT vaccine is given, right? But nowadays, since about 2013, DPT vaccine has been also modified, and it is DPT vaccine contains 3 parts: diphtheria, pertussis, and tetanus. But now, since 2013, it is given in form of pentavalent vaccine. So in pentavalent vaccine, there are 5 vaccines: diphtheria, pertussis, tetanus, hepatitis B, and H influenza B. These 5 vaccines are given. We are going to see the dosage also. So for prevention, key strategies are required to ensure continued prevention and control. There are 4 key strategies. Primary prevention, by ensuring high population immunity, how? By giving vaccine. Strengthening the surveillance, that is active search of the cases, early diagnosis and high quality case management, right? And rapid investigation and management of the close contacts. So again, I repeat, first of all, vaccination. We have to immune the population, right? For prevention, we have to make population immune. How we can make population immune? By giving vaccine, that is DPT and pentavalent vaccine. Strengthening the surveillance, that is active search of the cases, like in case of the corona we are doing. See, in corona all these things are we are doing, but just we do not have the vaccine. So first step we are not doing in corona right now, but we are in search of the vaccine, and it is expected that vaccine will be soon available. But strengthening the surveillance, active surveillance of the cases are already going on in various cities, in all the cities, right? Early diagnosis and high quality case management, it is also there in corona. In same in case of diphtheria, we diagnose early with the help of the RT-PCR, as well as nowadays rapid antigen test is available. Same in case of the diphtheria, early diagnosis by clinical feature as well as by laboratory investigation and management, high quality management, rapid investigation of the close contact, right? In case of the diphtheria, we have to also investigate close contact, right? In case of the corona, we are also investigating the close contact, right? So immunization, there are combined vaccines, active immunization and passive immunization. We are doing active immunization with the help of the combined vaccine. DPT vaccine, it is used for booster dose. Previously, it was used for the dose within 1 year, but nowadays within 1 year, pentavalent vaccine is there. There is also one DT vaccine. Previously, it was used. It is now not. It is not there as a part of government immunization program. This is single diphtheria vaccine, but you need not to remember this single diphtheria vaccine, because always this diphtheria vaccine is given in as a combined vaccine. Singly, only diphtheria vaccine, it is not given. It is given in combined form with the another vaccine, either as DPT or as pentavalent. Second thing is passive immunization by giving anti-sera, and then other thing is health education. So DPT vaccine, two types, plain and absorbed type. Absorption is usually done on mineral carrier. This is composition of the DPT vaccine. You can see the diphtheria toxoid. Diphtheria in DPT vaccine, diphtheria toxoid is used, right? Not bacteria, but it's toxin. It is called toxoid, right? Diphtheria toxoid is used for immunization. You know that Glaxo company is there. So 25 Loeffler unit of diphtheria toxin is there in Glaxo company, and as well as in Kasuli, the vaccine which is made by Kasuli, there are 30 Loeffler unit. Right? Tetanus toxoid is there, pertussis, so it is DPT vaccine. This is absorbent, aluminum phosphate, right? And thiamorsal preservative. Right? So storage of this diphtheria vaccine, all the vaccine, remember for all vaccine, it should be stored in 2 to 8 degrees centigrade, not in refrigerator, it is stored in ILR. All the vaccines are stored in ILR between 2 to 8 degrees centigrade. Remember in centigrade, forget about this Fahrenheit, right? So for vaccine, we remember this SAC test is also used, whether it is frozen or not, to check the vaccine, whether it is frozen or not. SAC test is also used. So in this slide, you just remember the temperature as well as name of the test, that is SAC test. Before giving vaccine, we have to check whether the vaccine vial monitor, it shows the temperature within 2 to 8 degrees centigrade or not. This we discussed previously also, and we will discuss about in further sessions, right? About vaccine vial monitor. Optimum age, it can be given as early as 6 weeks of the age, right? So it should be started at the age of the 6th week, right? It is given by deep IM injection in lateral aspect of the thigh, not in gluteal region and not in this deltoid region, because muscles are not developed in gluteal as well as deltoid region. So in child, we have to give at the lateral aspect of the thigh this DPT or pentavalent vaccine, right? So nowadays pentavalent vaccines in 2013, just we remember pentavalent vaccine is given. It is given as a dose of 0.5 ml. All these things are same for pentavalent. Route is same, site, dose, all are same for pentavalent vaccine. So there are, first of all, in primary immunization, those are started at 6 week, right? Penta 1 6 week, Penta 2 at 10 week, and Penta 3 at 14 weeks. So first dose of the Penta, that is called Penta 1. Second dose of Penta is Penta 2. Third dose of Penta is Penta 3 at 6 week of age, then 10 week after birth, that is after birth. 6 week, that is 1.5 months. 1 and 6 week means 1.5 months. Then 2.5 months, then 3.5 months, right? Remember this doses, right? Schedule. The booster DPT, then DPT 1 booster is given between 18 to 24 months of age, that is 1.5 years to 2 years. And DPT booster 2 is given at the age of 5 years generally. It is 5 to 6, but at the age of 5 years, DPT booster 2 is given. Right. So Penta 1, 2 and 3, 6, 10 and 14 week. DPT booster 1, 18 to 24 months. DPT 2, 5 years. Reaction following immunization, common reaction after this Penta and DPT vaccine is pain. Right? So among all the vaccine, this diphtheria, DPT vaccine as well as Penta vaccine, that is more painful. Right? There can be swelling, redness, and difficulty in walking. Not observed in all the cases. It is with the improved technique, this difficulty in walking, it is not observed commonly, but these are there, pain and swelling. And it can persist for 24 to 72 hours and respond this well to paracetamol. Pain as well as there can be fever, right? Pain local as a local symptom and fever. They are most common reaction following DPT and pentavalent vaccine. And for after giving this DPT or pentavalent vaccine, mother is always given paracetamol tablet. 1/4 paracetamol tablet is to be given 3 times a day to the child. Or you can give the syrup, paracetamol syrup also. There are combination of the syrup available. Plain paracetamol syrup is also available, as well as combination syrup like ibugesic plus. It contains this ibuprofen and paracetamol combination. It can be also given 5 ml 3 times a day, depending upon the child. 2.5 ml 3 times a day to 5 ml 3 times a day. So it can decrease, or it cannot give the reaction like pain and fever to the child, and child may be feeling comfortable. There are other systemic symptoms like destitute, anorexia, vomiting, irritability, excessive crying and screaming spells. It may lead, in some of the cases, very few cases, it is very rare. Excessive crying after vaccination or screaming spells. The child may be screaming because of the crying, that screaming, right, for greater than 4 hours, and it can lead to convulsion also. So that is about the complication, immunization. I mean to say reactions after immunization. Do you remember the dosing schedule? What is the dosing schedule of this vaccine? Dose schedule of pentavalent vaccine. Write down in chat box. Dose schedule of pentavalent vaccine, when it is given, at what age it is given. Till then we are discussing further contraindication of this vaccine are allergy and anaphylactic reaction to the previous dose. Relative contraindication are hypotonic, hyporesponsive episode, and deferral of P component of DPT should be considered in child, right? That is forget. If immunized with the P containing vaccine, if there is contraindication to P means pertussis containing vaccine, then we can give DT vaccine, right? Whenever there is contraindication to the pertussis component of the DPT vaccine or pentavalent vaccine, you can give DT vaccine, but it is also very rare. So I have asked about the dosing schedule. Let me check whether you have written or not. Dosing schedule. Yes, 6, 10 and 14 weeks. These are the primary doses within 1 year of age. And booster dose. What about booster dose? What about booster dose? Not 2 and 5 years. Second is okay, right. That is 5 years. First booster dose is given at between 16 to 24 months of the age. That is between 1.5 year, between 1.5 year to 2 years of age. Right. And second booster dose at 5 years of age. So that was all about the prevention and control of the diphtheria. So with this, we complete the topic diphtheria. Mainly, you have to remember in diphtheria from today's class that clinical features are, before clinical feature, you need to remember the types. 4 major types: tonsillar, pharyngeal, intranasal, and laryngeal, and other types like it can involve skin, eyes, etc. Clinical features, there can be soreness, there can be fever, right? 102 °F fever. That may lead to tiredness, and typical clinical feature is greenish yellow membrane. This membrane, it bleeds on touch, and there can be after this necrosis, whenever the membrane is necrosed, it may give the foul smell. It may give foul smell that is called foetor oris. So that is about typical clinical feature. Diagnosis is based on clinical feature as well as on staining. Albert stain is used. There are other laboratory tests, serological tests are available, FTA, ABS, and there are other tests for checking virulence, that is electrical precipitation test. For susceptibility testing, there is a test like seq test. So that is the summarization of the clinical feature and diagnosis. For prevention, you know that vaccine is available, pentavalent vaccine. You already have mentioned about the dosing schedule, 16, 14 week. Route is it is intramuscular route, deep intramuscular, lateral aspect of the thigh. Booster dose is for 2 booster doses are given, first between 16 to 24 months of age, and second booster dose is at 5 years of age. So that was summary of the topic we have discussed today about diphtheria. So now write down your roll number and leave. Some of the students have entered very late, so next time onwards I will not allow your attendance who have entered late, right? So only we will allow attendance of the students who have entered within 5 minutes of starting the class. Right. At the starting of the class, there were about 40 to 42 live views, and now it is 62. I will give you 30 seconds. So write down your roll number and then leave the class. In writing roll number, you are giving quick reply, but in question answer, you are not giving reply so quickly. Only few of the students are giving reply. "21" is written 2 times, 21 and 2. I will consider only the name 21, right? Not 2. Just write down your own roll number, not of your colleague. Okay, I think all of you have written.